Our 14-year-old. What about our young mother with puerperal sepsis? Would she have survived if she had a critical care physician looking after her? Then in terms of equipment, we should have had a saturation probe available for the case to do the thyroidectomy. But more to the point, we should have had a machine available to provide her with postoperative ventilation. Which we did not. Our patient who needed a blood transfusion, we certainly could have benefited from having a blood bank, not to mention a critical care unit that could have helped any of these patients. And then if you look at the systems of care, if we had a critical care system, if we had rapid labs available, could we have made a difference for any of these patients? So surgeons in low and middle income countries have experienced the challenges of delivering good care to their patients since time immemorial. We can't think of these challenges as new because we've all of a sudden discovered them as high income country physicians looking at inequities in care. But this was in 2011. And so at that time, there were whispers of this thing called global surgery, but the global health community was still really focused on other priorities. People at the time were saying things like surgery is too expensive or surgery is not cost effective. I mean, back in 1980, the then Director General of the WHO actually said that surgery clearly has an important role to play in primary healthcare and in the services supporting it. Yet the vast majority of the world's population has no access whatsoever to skilled surgical care, and little is being done to find a solution. So it's not like these problems were unknown. But then the oil shocks of the early 1980s came along. And so these multilateral and high-income country institutions focused on really trying to find magic bullets, things that could improve the health of populations while spending very little money. So investments in things like surgery was discouraged in favor of other cheaper interventions like vaccination. So the high-income country global health community really bought into this sort of mindset and focused on incremental change at a snail's pace. There were some early dissidents, though, and one of them was Haile Debbass. He's an American surgeon of Eritrean origin. And in 2006, he had written a whole chapter on surgical care in the second edition of Disease Control Priorities. And if you haven't heard of it, the DCP is a document that focuses on the economic evaluation of healthcare, and it was originally under the aegis of the World Bank. So Dr. Debbass argued that surgical platforms were cost-effective and worthy of investment. So this notion started to percolate through the surgical community, but even as of the early 2010s, when I was going through medical school, most people thought that surgery and global health were entirely divorced from one another. That was until 2013. And in that year, a group of high-income country surgeons decided really that they were tired of this sort of incremental change and thought this deserved a systematic investigation. So one of them was Andy Leather at King's College London, who had partnerships in Sierra Leone. Lars Hagander is a global pediatric surgeon at Lund University, and John Mira at Harvard had been working on developing a small global surgery program, and they had partnerships in Haiti and elsewhere. So they went to the Lancet with the intention of having a couple papers written on the subject, but they were unprepared for these two. So one of them was Dr. Richard Horton and the other Dr. Justine Davies. As many of you might know, Dr. Horton is the often controversial editor-in-chief of the Lancet. He has a global vision of the journal as both a repository for the best medical science and as a platform for global health advocacy. And Justine Davies is the inimitable editor of the Lancet Diabetes and Endocrinology. And she has a longstanding interest in health equity. And both of them saw this as an opportunity to do something a bit more ambitious. So they came back to the three supplicants saying, no, we don't really want to do a series on global surgery, but would you instead like to do a commission on global surgery? So the three vaguely knew what these commissions were, and so they agreed, having very little idea what they were getting themselves into. So what are these Lancet commissions? So in order to examine critical yet neglected areas of health and development, the Lancet started bringing together teams of experts to examine issues in depth in 2008. So they bring together a group of experts to assess what's deemed a crucial topic, and then they publish those findings in a report. And so since 2008, The Lancet has published a variety of commissions on a number of topics, from the education of health professionals to planetary health, global governance for health, and cancer care. And the overall purpose really is to generate large-scale sustainable improvement in these areas of global health and to drive policy change. So the commission document that's published is really only the starting point as a platform for further advocacy. So the Commission on Global Surgery started in January 2014, and the opening address at its first meeting was given by Dr. Jim Kim. And now Dr. Kim was the first person whose background was not in finance or politics to be the head of the World Bank. He was also the first person to have experience in health systems development to lead the bank. So this was a big deal. And in his address, he called surgery the neglected stepchild of global public health. And he encouraged the commissioners to not only use the platform for advocacy, but also to set up wayfinders to use the best available science to develop indicators that could be used to assess surgical systems around the world. So the commission then started in earnest. A global network of researchers was developed. The second meeting of the commission was held in the middle of a different pandemic that you might remember from 2014 in Freetown, Sierra Leone. So that was right at the start of the Ebola epidemic in that country. And by the end of 2014, 2 of Sierra Leone's 10 surgeons had died of Ebola, along with 8% of the country's health workforce. So you just take a minute to think about what that means on both a personal and health systems level with that kind of small community of health providers. And that really served to underscore the urgency of the problems the commission was tackling in developing surgical systems that were resilient and robust and included sufficient numbers of providers. So the commission set out as one of its goals to make its report and its recommendations based on as broad a consultative process as possible. So a big problem with other commissions and global health movements had been fragmentation, which we really wanted to avoid at all costs. So through a combination of qualitative research and collaborations, there were 110 countries that were involved in collaborating with the process. And in addition to the 3 universities and all of these collaborators, 7 journals agreed to be part of the process, publishing the commission's findings. So finally, in May 2015, after 18 months of nonstop work, the commission's report was published. So there's a great YouTube video that summarizes the commission's findings, and it's about 2 minutes, so feel free to watch it and share it. But we're going to unpack these findings for the next few slides. So again, if you've heard of the commission before and what it's found, this might be a little bit of a review for you, but I think it's worth sharing for those new to the field. So first, the commission estimated that 5 billion people can't access safe, affordable surgical anesthesia care when they need it. So the prior estimate was really 2 billion. So and that was along one dimension of access. So that was just looking at operating theater density around the world. Sorry. So this was Blake Alkire's work. So Blake broke access into 4 dimensions, all of which are necessary for care. So the first dimension was timeliness. As a proxy for how fast somebody can get to surgical care, he used the proportion of serious injuries that were transported by ambulance in a country. The second was surgical capacity, so the number of surgical procedures done in any country as a proportion of the number of surgeries that were needed. The third was safety, which is the proportion of operating rooms with pulse oximetry, so just a SAT probe. And then affordability, and the proxy there was the proportion of patients undergoing surgery who don't experience catastrophic expenditures as a result of their care. So he created a model which was run at the country level that took all 4 of these dimensions of access into consideration and then he summed it at the global level. So when you look at this on a map, you can see that the places where the highest proportion of the population lack access to surgical care are in sub-Saharan Africa and South Asia. But the problem is obviously a lot more nuanced than that. And these are modeled data. So there are error bars around the stated proportions, especially at the country level. But it does give us a sense of where the access problems are most urgent. The second finding of the commission was that 143 million additional procedures are needed every year around the world. And just driving the equity point home, they discovered that 1/3 of the world's population receives only 6.3% of the procedures done globally. And this was based on data from New Zealand, which was taken as an example of an optimally functioning health system, as well as data from the Global Burden of Diseases Project. So the third thing was that 33 million people each year face catastrophic expenditures just because they need surgery or anesthesia. So if you can imagine developing appendicitis and receiving the care that you need, but then being bankrupted and being forced into poverty as a result of the fees encountered for your surgical care. That's what we're talking about here. And that's just the out-of-pocket direct medical costs. And then if you add the direct non-medical costs of seeking care, an additional 48 million people every year around the world suffer catastrophic expenditures. So this was, again, another modeling exercise based on GDP, inequities economically, and the proportion of healthcare costs borne out of pocket. So it really drove home the financing mechanisms required for surgical care. So now this is the one where we really drive it home. So often people say, well, you know, that seems important and that's nice, but somebody's got to pay for it. And here's where the commission says yes, and it's excellent value for money if they do. So we found that scaling up surgical care in 88 low and middle income countries towards a minimum operative volume of 5,000 procedures per 100,000 population by 2030 would cost about $350 billion. And that sounds like a lot of money, but that's about 1/10 of the annual US healthcare budget, which is about 3.3 trillion US dollars per year. More to the point, surgery has been found to be incredibly cost effective. So this was another systematic review that was also done for the commission. So in terms of dollars per disability adjusted life year averted, general surgery was found to be about $82 per disability adjusted life year. If you compare that to BCG vaccinations for TB, that's about $50 to $220-ish. And therapy for HIV is on the order of $400 to $700. So it compares very favorably with these other highly cost-effective interventions that we advocate for in global health regularly. And just for reference, if you look at the cost effectiveness ratio we use in Canada to determine whether something is cost effective, the number we use is $50,000 per quality adjusted life year saved. So, so in that context, surgical care in low and middle income countries is highly, highly cost effective. But still, $350 billion is quite a price tag. So then the question is, what happens if you do nothing? So without urgent investment in this as a problem, low and middle income countries will have huge losses in economic productivity. And so when people get sick or die from treatable conditions, you can actually calculate how much that hurts the economy. And for surgical conditions, it's a heck of a lot. So if you look at this graphically over time and by disease category, you see huge losses in GDP every year from injuries and neoplastic conditions, so malignancies. By 2030, the loss is 2% of GDP per year. Now, other than COVID-19, there's very little that affects GDP growth by that much. So, so if you hear people talking about GDP growth, think about 2% per year in low and middle income countries without urgent investment in surgical care. And from that, we conclude that surgical care is affordable, saves lives, and promotes economic growth. Now, to further contextualize this, Mark Schreim estimated how much of sickness around the world in general is attributable to surgical conditions. And the previous estimate was 11%. But using GBD data, he estimated that about a third of disease around the world is surgical in nature, meaning that it's amenable to treatment via surgery, making surgery an indivisible, indispensable part of healthcare. Now, if you recall, as Jim Kim asked the commission, we needed markers of the quality and accessibility of surgical care in each country. So the commission came up with 6 time-bound targets to assess surgical systems at baseline and to track improvements over time. And these can really be applied to the surgical system in any country. So they're organized according to the preparedness to deliver surgical care, the actual delivery of surgical care, and finally the financial impact of accessing surgery on the population. And they're really meant to be assessed together as a whole and not as individual indicators. And we actually have managed to provide the World Bank with data on at least 4 of these metrics, which are now included within the World Bank's World Development Indicators. So finally, and this is perhaps the most important thing to come out of the commission, was the concept of an NSOAP. An NSOAP stands for National Surgical, Obstetrical, and Anesthesia Plan. So this was the template for an NSOAP that the commission came up with. So it fits on a single side of a page. So there's obviously a lot of detailed data and local context that needs to be added in order to craft a real life NSOAP. This is a basic outline of it. So you need a plan for infrastructure, workforce, service delivery, how to pay for care, so how you're going to finance it, and then how you're going to collect data on your system. So this is obviously the most critical part of this whole process. It's all fine and good to measure the problem and declare it as such. But unless local and global actors really address the access gap, we haven't helped anyone by simply describing the problem. So the Zambian government pioneered the NSOAP approach. They published a 112-page document in May of 2017 that planned out how the government was going to address surgical inequities through 2021. And since then, other countries like Rwanda, Nigeria, Tanzania, and Ethiopia have all come up with their own NSOAP plans. You may have seen this on social media recently. UNITAR, so the United Nations Institute for Training and Research, published the NSOAP manual. And the NSOAP manual is a technical document that national governments can use when developing their own NSOAPs. So this is really powerful stuff. So we've gone from highlighting a global health equity problem to concrete solutions on the national level within 5 years. We have a long way to go, but it is a start. So switching gears a little bit, how does this sort of work differ from traditional global health research? So historically, global health research has involved primarily high-income country, mostly white researchers flying into low and middle-income countries where they engage in superficial survey work, collecting data, often on clipboards, which is why you see this sort of clipboard army caricature of global health research. Oftentimes, there's very little local collaboration or context, and then they're gone. So this approach to global health can be really exploitative. The benefits are typically quite one-sided, and there's a potential for real harms. So if the health of population is going to improve, it's not because some young high-income country researcher found his or her way to a low-income country and finds the answer miraculously, and especially not in surgery. So we know in surgery, real growth and access needs staff, space, and systems. And those things don't materialize just because someone wrote them on a notepad. So and that's not to disparage the work of motivated and thoughtful people, of course. The commission that we talked about started as a discussion in high-income countries before rapidly evolving into a global collaboration. But the success of the commission was in part due to the anti-colonial way in which it was conducted and written. So what do I mean by anti-colonialism? And this is part of a broader reckoning that's going on in global health research now. So anti-colonialism starts with a recognition of the role that colonial powers have had and continue to have in creating structural racism and structural violence. It's then a commitment to first not perpetuating structural violence and second to seeking it out and dismantling it. So, as I said, the world's really facing a reckoning in the colonial impacts on health. Um, we're currently figuring out that the West doesn't have all the answers. Um, so if you look at this comparison of COVID-19 cases per million population from our world in data, you see the US, which is historically the largest funder of development assistance for health, with an extraordinarily high number of cases per population. Canada's doing better, but still not great. Then you have Rwanda, which is a densely populated African nation that barely saw a blip in the spring, and has since crushed the pandemic with a well-coordinated technology and data-rich response. And then even South Africa, which had a major surge during their winter season, they've since brought down their new infections to half of Canada's rate. So what does that mean for global health? And if high-income countries don't have all the answers, where does that leave global health? So this is a great article, and I think it's worth reading for anybody thinking of engaging in global health work. They look at the legacy of colonialism in global health in the context of the COVID-19 pandemic. So they call for three things. The first is a paradigm shift where global health is repoliticized by grounding it in a health justice framework, acknowledging how colonialism, racism, sexism, even capitalism, and how other harmful isms pose the largest threat globally to health equity. The second is a leadership shift that they call for, with greater leadership representation at global agenda setting institutions like the WHO, UN, and World Bank, more representing the diversity of people that those institutions are intended to serve. And finally, a knowledge shift to ensure that knowledge flow is not unidirectional, but instead reciprocal, with contributions from the global South driving discussions and practice both locally and globally. And if you need an even bigger kick in the pants, you really need to read this article by Desmond Joombaum. So this article really challenges all of the behaviors of high-income country researchers when they pay lip service to appropriate global health practice. So the bottom line really is, if you want to be effective in global health and you really care about population health, you need to check in with yourself regularly and ensure that extrinsic motivating factors like grants, et cetera, are not pushing you to reinforce structural violence. And more to the point, recognizing and promoting the powerful agency of clinicians and researchers in low and middle income countries. So by way of conclusion, effective health systems, including surgical systems, require the 4 S's. Surgery is important for saving lives, preventing disability, and indeed promoting economic growth. The global health landscape really is changing. In order to be helpful in this field, you want to recognize your position in the global health infrastructure and making sure that you're acting in a way that that decolonizes global health by dismantling structural violence in your work and amplifying voices that aren't already magnified by privilege. So that's a bit of a sweeping overview of global surgery so far, with a bit of context in terms of how things are evolving today. And I'll be happy to take questions at the end.
So thank you, Dr. Ng, for that very comprehensive introduction to global surgery. We really appreciate your insights. I'm going to go ahead and introduce Dr. Ma. She'll be speaking for the next half of the session. So Dr. Ma is a recently graduated physician from the MD-MSc program at the University of Montreal. Her involvement with Incision dates back to 2017, where she served as Vice President for Internal Affairs for 2 years, and then supervised the development of its national chapters and built the internal structure during Incision's early years. Since 2019, she's been the co-chair of Incision and has had the pleasure of growing with fellow colleagues on the executive board. So Dr. Ma is here to kind of talk about the structure of Incision and a little bit more about how medical students can get involved on a more international stage.
Thank you so much. I'm just going to share my screen. So can you guys see that? Okay, awesome. Hi, everyone. My name is Shia, and I have the pleasure really today to introduce you to Incision, the International Student Surgical Network, of which CGSTA is one of our member chapters. So as Brinta just introduced, I am one of the co-chairs, and here we go. So Incision, also known as the International Student Surgical Network, is the world's largest trainee-led global surgery organization. And the idea of our organization is really to be a not-for-profit group of medical and public health students, residents, and early career physicians in the field of global surgery and anesthesia care. And the way we are organized really is that we have an international team, and we represent more than 5,000 members in more than 80 countries around the world. We currently have more than 50 national working groups. These are national chapters, just like CGSTA is one of them. And we're fastly growing. I think by the end of this year, we'll easily reach 60. So it's actually a really exciting time for us, despite some of the challenges that 2020 has provided us. So here are kind of like our vision and our mission and what we think is really important within our organization. So first of all, we want to work towards timely access to safe surgical, anesthetic, and obstetric care for everyone, everywhere when needed. So how do we do this? Is by uniting, developing, and mentoring future surgeons, anesthesiologists, and obstetricians of the world. And at Incision, we really care about these following values, which are capacity building, collaboration, diversity, education, equity, integrity, and mentorship. And really every one of our activities is really centered or stems from these core values. Just a quick introduction to how we are structured. So this is kind of how our international team looks like. We're actually a really huge group. I have a picture afterwards to give you an idea of how numerous we are really. So the group is led by the chairs, which are myself and Ketayu Madani, who is my co-chair. She's a physician who studied in Grenada, but she's currently in the United States. And we have a wonderful executive team of 9 people, which includes someone for external affairs, internal affairs, someone for national chapters, VP finance, and then 3 sub-team leaders, which are our different fields of work, if you want. There's the advocacy, there's education, and there's research. Helping us in this whole process are also our board of trustees, which are often our alumni or people who really care about our mission and are there to kind of guide us throughout our activities if we need guidance. And finally, our board of advisors, who are very well-known, established individuals within global surgery who are there to, occasionally give us advice when we request it. This is our team for this year. I think I have most of the pictures here, but probably not all of them. But as you can see, we're a very, very diverse group of people working together. We're actually 53 members, 26 women, 27 men from 33 countries, where when you divide it, it's actually 26 low and middle income countries and 27 high income countries. And we cover over 30 languages, which is really incredible. And I think one of our biggest strengths within Incision is this diversity, is because so many of our members come with very different experiences, different perspectives, and it really enriches the kind of activities that we can bring to our to the world, really. So just a couple words on advocacy. That's one of our main sub-teams and activities. We are actually very active in a couple of annual campaigns, which celebrates really important days and brings more awareness on certain topics within global surgery. So just to give you an idea, every year we participate in International Day for Maternal Health and Rights, which is on April 11th, Global Surgery Day, which is actually a event that Incision itself started 5 years ago. And it's a day where we celebrate the field of global surgery and all of the advancements that have been that have happened over the past year. So I have a couple of pictures afterwards to give you an idea what that looks like. World Anesthesia Day, which just happened recently on October 16th, also World Trauma Day, October 17th, and then coming up pretty soon, December 12th, is Universal Health Coverage Day. So in the context of these advocacy campaigns, we also collaborate with a lot of leading organizations in global surgery, including, but not limited to, these that you see here. So the World Federation of Society for Anesthesiologists, Lifebox, which was funded by Dr. Atul Gawande, maybe some of you have heard of his name. And also the G4 Alliance, which is a group that works at the World Health Assembly level for namely advocacy. So this is a picture of one of our national working groups in Rwanda, one of their advocacy pictures during Global Surgery Day. And also in the past, we've done global surgery stories. So basically inciting our national chapters to kind of share some of the stories they have experienced within global surgery. This is one of the posters that I believe Incision Japan made. And finally, this is Universal Health Coverage Day, so a poster to celebrate that event. And this was actually our schedule for this year. Because of the pandemic, we weren't able to hold an actual physical event. So we wanted to have this campaign, which really spanned over 2 days, including different activities, including live chats, Q&As, webinars. So it was a really exciting day. I think this was our biggest celebration yet. And if you happen to have joined, you would probably remember how exciting it was. We also work in terms of research. Here are some of the examples of some internal projects that we have done in the past or are currently doing. So one of the most remarkable contribution of Incision actually was that in 2016, our team actually helped collect data for the World Development Indicator for surgical indicators. So that's one of the examples of some of our contributions. I'll talk a bit about the external collaborations we have afterwards. So just to go through these quickly, we do have a journal club that happens on the second Saturday every month on Twitter, which has been a real success over the past month. So if you happen to have a Twitter account or if you create one, then we definitely encourage you to participate. We have a research mentorship program within our network so that we can help empower some people, especially those in low and middle income countries who might not have as much mentorship in terms of research. And also we've conducted recently a little series of capacity building within research, and we're actually currently wrapping up a paper on that. So this is an example of one of our promotional posters for our journal clubs. It can really span any topics within global surgery, and we usually get a really exciting turnout. So definitely have a look if you're interested. Some of our external projects include a collaboration that we're doing with Ariadne Lab and Lifebox Foundation. So it was part of an effort to celebrate the 10th anniversary of the surgical safety checklist. And the data collection actually ended last year. We're currently in the process of wrapping up the paper. And finally, another notable one is the LARC GSSA and Incision project. So it's we have a couple collaborators in the Latin American region, and we also have our national chapter in the United States working together in order to survey the interest in global surgery research among students. And this was also a project that recently ended in February this year. In terms of education, we really want to help out in terms of capacity building, mostly internally, but also externally. We focus also on public education, and we want to provide opportunities for people to just learn more about global surgery, and then eventually give them the tools to get involved as well. So to give you a couple of examples, there's this activity that we did recently, which was on developing and improving your management skills. We got a couple of our members in the international team to talk about their experiences and to share that with the broader audience. And another example is the impact of COVID pandemic on research. We had Dr. Ramos who came to chat about this topic, and we had a really amazing turnout. So these are some of the examples of, and also this one, global surgery and universal health coverage in the era of COVID-19 pandemic. You know, obviously this pandemic has been very devastating for many, but I think, you know, Incision and many other organizations have really taken this opportunity to improve on these kind of virtual teachings and provide more opportunities where, you know, some doors have closed for people. Finally, I want to talk about the Incision Global Surgery Symposium, also known as IGSS. So this is our annual symposium that we started in 2018 in Leuven, Belgium, and have ever since done one every year. So this was in Belgium in 2018. Then our second edition was in Rwanda, Kigali. And finally, our third edition, which is coming up on November 6, 7, 8, 14, and 15 is going to be virtual in collaboration with Incision Colombia, our Colombian chapter. So unfortunately, it was originally supposed to happen in Colombia, but the pandemic happened, and but we still really cared about having this project forward. So we decided to take it online. And that's also one of the reasons that it's 5 days long, is that we don't want to keep people on Zoom for, you know, the whole day. And hence we spread it over 2 weekends. So just to give you a couple of ideas, this is the pictures from the first IGSS, second IGSS, which you can definitely see the expansion. If you're interested in joining our third one in November, registrations are currently open. And so here's a link. You can go there to register. The ticket prices are about $10 to $20. So we tried our best to make it very accessible for everyone, and to make sure that everybody would get a chance at participating in this, this symposium. To give you an idea, we have some world leading experts who are going to join us. We also have presentations, abstract sessions. So it's going to be a really exciting event. So to touch a bit on our national working groups, we're probably nearing 60 by the end of this year, and this gives you an overview of where our chapters are situated. We always look forward to collaborating with new people and to expand within the countries where we have not yet had the chance to reach. So if you're interested in getting involved with Incision, there's a variety of ways. First of all, create a national working group in your countries. Thankfully, we already have one in Canada, which is CGSTA. If you're interested in joining, I highly recommend it. I was involved last year, and I think, you know, this year we have an absolutely incredible set of people who are leading this initiative. So I think it's going to be really, really exciting year to come. Second, you know, social media is always a great way to stay updated on our latest activities, and sometimes we have calls and opportunities. So staying tuned is never a bad idea. We have a Facebook group where we share global surgery news, and of course the Global Surgery Journal Club that I've discussed earlier. And yes, there is a possibility of joining the Incision International team. Our applications open every December, so that's actually coming up pretty soon. It will be for 2021. So if you're interested in getting involved at a more international level, then there is a possibility to join there. Or if you just want to get involved more on a national or local level, CGSTA is a credible place for that. So that's pretty much it. I'll be happy to answer your questions. If not, here are our website, emails, and all the handles we have on social media, which I realize is quite a lot. But really, that's the way we communicate nowadays. So yeah, thanks a lot for your attention.
Right, thank you, Dr. Ma, for going over Incision and your role in Incision. That was very helpful for all of us. So we're now at the end of our talk, and I know we're kind of reaching the 1 hour limit. So if you have any questions for our panelists, feel free to put them in the chat, or you can unmute and ask yourselves. Yeah, so I'll kind of give the floor off to the students now.
So I guess as we're waiting for questions, I just wanted to say thank you to everyone for attending. It was so nice to see such a great turnout. We would love to hear from all of you. I would love if we had enough time, you know, to actually talk to every one of you and see what stage of training you're at, etc. In the chat option, I did put our Gmail account of the CGSTA for as well as our Twitter and Instagram. And you know, with COVID these days, it's so hard to. I feel like social media has become the main mode of communication. So we would love to hear back from you if you have any event ideas, like if you have questions, concerns about at the medical school level, student level, if you have ideas about what are some things about global surgery that are relevant to you. And also, like I know with COVID, of course, international electives are not something that can happen, unfortunately, for medical students. But any questions, concerns around that, we would love to hear from all of you. So I think for the sake of time, Brintha will be wrapping up the event pretty soon. As I said, feel free to reach out with any questions if you think of them later on.
So feel free to email us any questions that you may have, and as well as any event ideas or just any interesting global surgery, and we'll try our best to connect you to the right people. But with that, I will wrap up this event. So thank you so much, Dr. Ma and Dr. Ing Kamstra, for coming to this talk and for imparting your wisdom and your experiences on us. Is very much appreciated, and we look forward to seeing many more of you at our future events as well. So thank you very much.
Thanks for having me. So if anybody has any questions about anything, feel free to DM me on Twitter. I'll put my email here in the chat as well. So if you want to send me an email about anything, feel free.
Same here. Thank you so much for the invitation, and I look forward to what you guys are going to do this year.
Yeah, thank you so much. Thanks, Josh. Thanks, Shea, for coming. And I actually want to quickly thank the CGSTA team as well for putting together this event. Thank you all so much. It's been a great effort, and hopefully we can bring more events as well in the future.
Amazing. Thank you, everyone.
Thank you.
Take
care, guys.